thanks everyone on the panel for joining us today. It's great pleasure to connect with you, though virtually. When we accepted the offer to be part of this discussion, we were all hoping to meet in person and break that chain of being in-house or working from offices and small cubicles for a long time. But unfortunately, that could not be. Thanks a lot to the participants who are there. I can see over 150 participants right now there. Thanks for investing your time with us today, and for CSRBOX team for organizing this 3-day event. Being part of some of the earlier panel discussions, really interesting to see different perspectives coming in. In terms of today, we are going to, as we're going to discuss a very key issue, which is of course not new. We're going to discuss the public health priorities in the country and how programs around health and nutrition can be more inclusive. This is not a new topic, and something which has been part of the dialogue for the last 20, 30 years, at least since I've been part of the sector. But the last 2 years have shown all of us that things are pretty dynamic. The pandemic is dynamic, and it brings a new perspective to things. The way we were planning or we were working earlier does not stand true today. And as we move forward, it's going to be very, very different. The kind of world we are entering into, it's going to be challenging, and new ways of working and new ways of thinking will need to be brought in. Looking at the context that we are in today, just a couple of weeks back, the NHFS 5 data came out, and one really sees that while India has made strides of development and different indicators, there are a few areas of concern that still remain, specifically around anemia, level of malnutrition, which in many ways are the key determinants for the public health or for health of our population in general. And without taking much of time and boring you with data, two interesting things come out, that anemia per se has kind of deteriorated across age groups, and some geographies, of course, doing worse than the others. But the basic thing is that it's dropping across age groups, key concern. On the other hand, while in the past we have always been focusing on malnutrition, but looking at only from the perspective of undernutrition, this particular survey comes out with an interesting fact: the level of obesity increasing, and one can only kind of say briefly how kind of impact it can have on NCDs, and that may be an ensuing pandemic that we may be looking at going into future. And we of course saw during the COVID-19 different last 2 years also that people with NCDs were more prone to the severe impacts of the virus. So going forward, what is required? I think mainly for different stakeholders right now, the challenge is, and by stakeholders, I don't just mean the corporates, but the government, the civil society, the other donors, bilateral, multilaterals. The biggest challenge is whether to right now focus on addressing the challenge of the pandemic or look at the regular programming that the health sector needs. And in the last 2 years, the regular programming has taken a big setback, be it areas of immunization in general, antenatal, postnatal care, nutrition programs, midday meal, supplementary nutrition, all have suffered a lot. And some of the other areas like the NCD or the geriatric care, etc., which need the focus, have kind of been totally sidelined. Now, given this kind of a scenario, the stakeholders then definitely need to come with new ways of working, new ways of collaborating with each other, understanding each other's perspectives. And that's something that we would kind of try to address through this panel discussion. And that's basically very, very critical when it comes to us achieving the global agenda for 2030, leaving no one behind. And we have actually lost a couple of years in that. I don't know how many more years we may lose to the pandemic. But as we were listening in the previous panel as well, we have possibly in certain areas moved back to 3 years. So the loss is not only the 2 years we lost to the pandemic, but 3 years or the backward progression we took. So given all that, and I think without taking more time on general discussion, I would like to kind of just get into getting your perspective, given that you all work at the grassroots level through your organizations. And maybe start with Ms. Aman, Pannu, with you. In terms of Aman, you come from an industry house that has a big historical legacy when it comes to philanthropic giving and social responsibility. It's not the CSR law that made the Shriram group start investing, but much before that. And it's a part of your, I would say, ideology per se. Now, when you program today, when you implement your CSR initiatives today, how do you ensure that your programs are inclusive and take care of the equity considerations that are required? And how do you ensure that the government programs that are running in parallel, you complement them and you work closely with them, and then your end beneficiaries or the communities that you're working with are also able to benefit from these projects? So some perspective around that would be really useful to kickstart the discussion from your end.
Thank you. Good afternoon, everyone. Thank you, Himanshu, for setting the context. And like rightly said, I think it's a very important subject. So I'd like to thank CSRBOX also for putting this on the panel. I'll try and answer your question in 3 parts. So rightly said, DCM Shriram has a very strong heritage of more than 130 plus years. Our founder, Sir Shriram, was somebody who had a strong commitment of giving back to the communities as a philanthropist, as a nation builder. And this was much before the CSR Act. So people from North India would be aware of institutions like Shriram College of Commerce, Lady Shriram College. So we had a lot of focus in terms of working in areas of education, women empowerment, I think. And this is something that, when we talk about inclusivity, I think I'm happy to say that all our programs mirror his vision only. So in a current scope, of our conversation, I'd like to talk about a project that we have called Khushali Sehat. So this is a mother and child health program, which we are running in the geographies of Hardoi and Lakhimpur Kheri in Uttar Pradesh and Kota in Rajasthan. And the key objective of this program is to reduce IMR and MMR in our program villages. The program layer focuses on vaccination, immunization, nutrition, family planning, institutional delivery, and MHM. We impact about 14,600 families across 44 villages. And what we do is that the project is set for 3 years. Every 3 years, we move to the next set of villages once we have achieved 0 IMR and MMR. That's the objective that we work with. Specifically, I think on the nutrition piece, we have Sehat Didis, who are part of our implementation partner organizations, and they work with the government field workers, the ASHA, the Anganwadi, the ANM, and they supplement their efforts, right? So we host, say, Matra Samuh Baithaks, Kishori Baithaks. So a lot of conversations on behavior change, which is related to nutrition for the pregnant, lactating women and adolescents. And, if you look at data also, behavior change around nutrition and hygiene, there's a baseline that we do. And if the baseline in, say, iron and folic acid consumption showed 63%, this year it has gone up to 92% in our program villages. Similarly, we do a lot of focus on strengthening of the village health, sanitation and nutrition days. I think that is something which is, the government also talks about the fact that how this platform is being used very efficiently and converging the services. So I think not working in isolation, but working with the government field cadres have been our key from beginning of the project. We do a lot of one-on-one interaction also through our Sehat Didis, where they go and speak to the identified malnourished beneficiaries, right? The second question that you were talking about was about the health and nutrition programs. And I think the focus here for us is naturally, what are the sort of solutions that we as corporate sector, as foundations, as social sector organizations can take up. So the entire government machinery, the ICDS department, I think all of us are focused on improving the nutrition levels of the mother and child through all of the various initiatives which come under the Poshan Abhiyan, because naturally there is a very direct correlation to the IMR and the MMR ratio. Also, we see a lot of deaths happening because of in the neonatal cases, in where deliveries are happening before time. So all of this is correlated to the nutrition aspect also. And I think somewhere the success of these programs is kind of dependent on the commitment on part of the government, the bureaucratic leadership also. And there is definitely a need to push for creation of some mechanism where the state, the district, the block, and the village level, where they kind of accelerate this convergent action of the government departments, of the social sector, or foundations working together. I think towards this implementation agenda is very, very important. More focus, I think, in training and capability building of the field cadre. That I think we've seen when we have trained our Sehat Didis, the kind of impact that it makes. And when we train them, we also do train the Asha, Anganwadi, and the ANM in our field villages. And you can see the difference when we look at, the control and the treatment areas that we work towards when we do an impact assessment, right? The identification of malnourished beneficiaries, I think, is very, very important. And somewhere when we look at the data and what is happening on the ground level, there's a lot of differentiation that we can see. So there's definitely a need to address some of these issues. So I'm just going to share like a short case study, right, that kind of talks about this malnourished data that I'm talking about and how it's important to be more open on this data. So last year we had run a pilot for mapping about 640 of our malnourished pregnant lactating women, children and adolescents in our 44 program villages in Hardoi and Lakhimpur Kheri. We took the indicators as BMI levels, which were below 17. We did mirror tests to understand the anemia levels. And for this specifically, we did a training for our Sehat Didis in terms of how they can map the malnourished beneficiaries in our area, along with doctors who, were holding health camps, which were set up specifically for these identification purposes. Now, post the identification, we worked with the beneficiaries for this year in how do we improve their BMI levels through providing them portion kits, which were especially designed by Akshay Patra Foundation, which had higher food in terms of iron and folic acid. Also, what we did was that the Sehat Didis had regular interaction, conversation with the beneficiaries on their nutritional intake. The doctors' checkups were regular, and the impact assessment that we just finished last month showed us that about 63% of the malnourished stakeholders' BMI levels had shown positive change over the baseline. So why I'm sharing this case study is that, it becomes important to look at this data point and see that what the government machinery is saying and what is happening on the ground level. Sometimes there's a lot of disparity, right? So how do we keep this data more open is very important. We're looking at a scale up of this now to the entire block level. And that's where we're looking at a convergence with the government department, because it's very important that when we look at scale, it's not possible for one organization, one social sector or corporate foundation to be able to make that sort of impact, right? So the learnings that we have, we want to help support the ground efforts of the existing government schemes also, right? And lastly, the point that you made about how communities can get access to government schemes. I think despite, this large gamut of programs and schemes which target mother and child and nutrition, the uptake of the nutrition services, as data shows us, is still very low, right? So I had called out some data which was there in the NFHS 4, which spoke about the fact where, 51% of pregnant women attended the minimum 4 antenatal services. 30% of them only consumed the iron folic acid supplements. The number of beneficiaries who take home the supplementary nutrition program also, it varies from 14% to 75% for children and about 51% for pregnant women. So some of these data points, I think, are important for us to see how we as corporates, as social sector, can bridge this gap for these beneficiaries and help the beneficiaries get these government schemes. So again, to give you an example, there was a scheme that we run with an organization called Indus Action, which is a social organization. We trained our Sehat Didis to facilitate in helping lactating and pregnant women to get access to the scheme Pradhan Mantri Matru Vandana Yojana. So I'm sure all of you are aware that Pradhan Mantri Matru Vandana Yojana, it's a government of India sponsored scheme, which basically provides direct cash benefits of about 6,000 to pregnant and lactating women on their first pregnancy, right? So when we did mapping of our pilot projects in our area, we mapped about 817 young mothers and pregnant women across our 44 program villages. And we tried to understand that how many of them were either aware of the scheme or had they taken benefits. And we saw that about 288 of them, they were not either aware of it or they didn't have the relevant documentation. So we helped in facilitating that entire process, which further resulted in unlocking a benefit about 17 lakh to our beneficiaries, right? So I think, in terms of just a closing remark, I think it's important to look at this range of the initiatives and programs to fight malnutrition or undernutrition, and look at how we can't work at a macro level. It's very, very important to work at a micro level, and especially with this SDG talking about the fact that how no one should be left behind. So it becomes very important that we do some need-based alterations also in order to reach and to influence every individual that we want to reach out to as part of all the schemes that we are talking about. Yeah. Thank you.
Well, thanks a lot, Aman, for sharing your perspectives and giving real examples of the work that you're doing on the ground, especially like the focus on conversation, BCC, and working at using the government structures, be it VHSND or otherwise, to reach out to the communities. I think that's the way corporates can contribute a lot, and the focus on impact assessments so that the learnings can be used by government to scale up. But one point that you raised, which was very critical, was mechanisms for acceleration and convergent action at different levels, be it a district, be it a state, or be it at the national level. And that's where I think, moving to Joydeep, Vedanta has a large and well-designed CSR program with different verticals, and you work both at the national level. Some programs are large, some are kind of to specific locations. So how do you work with the governments, and what's your approach for collaboration for a structured kind of a collaboration at different levels? And also when you're specifically working, say, at a small unit or a district around your facilities, how do you ensure that the learnings or the projects that you implement there can be then scaled up within the government system? So that would be something that I think would be really useful to understand from a large program perspective.
Thank you, Himanshu, and good afternoon, everybody. And thank you, CSR, to share our experiences. So I will, Himanshu and others, I will start with the convergence point first, and then I'll come to Vedanta as how we do. So why I feel that convergence is more important, and you talked about the NFHS 5 data, and particularly around indicators around anemia, indicators around nutrition. What we need to see that the ICDS program has been running for the last 50 years, and the change is just, I would say, just an incremental change. It has not even moved to a level that we say that, okay, we have created an impact. Now, why it is happening? And there are several reasons to it. One of the things is that what we are trying to do within the ICDS program is trying to just look into MCH, or 0 to 6 years pregnant and lactating mother. But we are not looking into the entire public health. It's a public health issue, not just a mother and child health issue. And what is happening, and what we discussed before also, is that ICDS, like an HIV program, is a very vertical program. And when you run a vertical program, it becomes focused, and it starts with when you start a vertical program, you know that, okay, these are the vulnerable communities we need to address, and that's why we design a vertical program, HIV, TB, or nutrition. But the issue is larger. So for a WCD run program, we need to also see how do we integrate with the MOHFW. And then how we need to, with the COVID situation, how we need to integrate with other departments as well. So that is very, very important, and that is critical. And I think all of us understand that, and that's not only civil society, but corporates as well as academic institutes are now focusing on, that we need to carefully look into it. The other important point is around, yes, importance of capacity building, but are the frontline workers, ASHAs, Anganwadi workers, ANM, they are too overburdened. at this point. And we expect them to do everything and to find a solution for everything, including doing a census for us. So we need to be very, very careful in setting up the targets. We set up targets and give them targets which are too ambitious for them to achieve and beyond their capacity. So that's another thing that we need to look into it. And that's where I believe the role of civil society and corporate comes in. And how do we pitch in? Because we will never be, as corporates or civil society, be able to replace government, the scale at which they do, the machinery they have got. Our role is primarily to create good practices. And we will do it at a very smaller location using the government system and see that, okay, it can work. And this is the way it can be made workable. And then pass it on to the system to make it sustainable. Now, what is happening with, and I can talk about corporates, have focused, all of us have focused, like Himanshu, you said that when the CSR rule came in 2014, most companies used to do community development. Community development is needed because you need a social license to operate within your area. And you need to provide all kinds of services so that you provide quality of life to the people who are working within your organization and the communities which are residing near your locality. 2014 regulation made corporates to focus it more towards like a donor-driven kind of approach, that how the program needs to be focused, where you need to implement, talk more about the impact, like what Ms. Pannu was talking about. So clearly moving from philanthropic to a program implementation and program management point of view. And I think as at Vedanta, we have also learned it over a period of time. And we are, I would say that, constantly learning, constantly moving and moving towards innovation. So how we do in implementation in our areas. Earlier, as I said, that we used to do the work in the communities. Now we have started working very closely with the civil society, working very, very closely with the government. So when in our plant location, we will get two kind of requests. At some time, I won't say because they say that, okay, you have to do it. So we have to decide on how we and prioritize it and then do how we need to do it. But the strength, what we have realized that we can have negotiation with the government and government machinery is that when we are actually able to create an impact about the program and the communities are on our side and saying that, okay, this program is real. Like, for example, that we do a lot of work in Barmer. And in Barmer and around locations, when we started working initially, obviously community knew that a big company like Vedanta is working and they were coming to us. But slowly we have provided education, water, nutrition, and all those. And now we have the community at our side to provide us that need to have that kind of discussion with the government machinery. The new location where we have moved in is Assam in the northeast, particularly in Jorhat. And Mr. Kiran would know in ONGC, fantastic work in northeast. We were new players there. And so what we did, again, work with good organizations, grassroots level organizations, and take their expertise because we know that they have the capability. We need to provide the grant, and we didn't give a huge amount of grant. And that's why I said that we have learned over a period of time. Right. You give grant which is aligned to government priorities. You give grant which is according to the market rate, but then you don't give grant which creates unnecessary demand. And right. So in Northeast, we are focusing on self-help groups in creating a lot of work around, because water is a lot available there, water harvesting around agriculture and all kind of gamut of things what we are doing. The other important flagship program of Vedanta is the Nanghar programs. And so we have created 4,000 Anganwadis currently, and we will scale it up to 20,000 in the next 3 years. And there again, the integration is happening. Yes, we are working with the WCD in the first half. In the second half, we are working around the skill development. And now we are bringing in the aspect of the One Health. Because the Anganwadi is there, you have a center, where you can provide all kind of services. And you can use that premises to train women in building. You can work with the communities. You can work to provide other services. I will stop here and then keep.
No, that's really useful, Joydeep. Just one follow-up question on that from the point that you mentioned about the different initiatives. Do you feel there is enough avenue available for interaction with the government to kind of take care of some of these areas? And what do you feel that can be done more from government side or from platforms like CSRBOX to have a kind of a structured discussion between government and the corporates to enable all these efforts and see that there are synergies across? Quickly, if you could respond to that.
Yeah, absolutely, Himanshu. I think there is an opportunity there, and Niti Aayog provides that platform, particularly when you start working in the aspirational districts. They will provide you that platform. They will give you all the avenues to work in that districts. It's upon you as a corporate to use that opportunity to create an impact. The other thing which I want to add, Himanshu, for corporates to understand and do is that we are not into the business of implementation. We are not that experts. The NGOs are international NGOs, local NGOs, and civil societies are experts. So our role is primarily to fund now on the R&D and innovation, and create an innovative approach and best practices. And that's what we will do. Just to tell you that at Vedanta, we have now moved into Anil Agarwal Foundation, and we have clubbed everything into 5 buckets. One is obviously the business area, but then one health, nutrition, skill building, and livelihoods. And that gives us an opportunity to, like a BMGF kind of approach, you focus on thematic areas, create an impact, and work around innovation. And obviously it gives you a much more easier, because if you do 30 different things, then
it becomes difficult.
Yeah, absolutely difficult for you to have that negotiation with government, and government will not take you seriously. So have 4 or 5 buckets and then work closely with those departments.
Thanks a lot, Joydeep. And I think 2 main points that you brought in were very, very critical, that be aware of the platforms that exist at Niti Aayog or at the MOHFW or other ministries level, and depend upon the local capacities. There are enough good organizations working at the grassroots. And of course, that structured approach, looking at each thematic area, I think that is very, very key. And that kind of very easily brings me to Mamta.
So before you move to the next panel, can I add one more point?
Sure.
Sorry, is that as corporates, because we have the fund, and the government also has fund. Most of the funds are not utilized. They come at the end of the financial year. So we can support in bridging that gap when you budget, and that should be something which corporate should really look at, particularly looking into your PIPs, where the money fund is a lot of untitled. So thank you.
Truly right. And I think this time around, some of these state governments are trying for a 2-year PIP to start with rather than an annual PIP. So like corporates are getting the option to do 3-year programming, the governments are also trying to match that with at least 2-year PIPs to start with. But coming to you, Mamta, I think what Joydeep mentioned, having a structured approach, a focus area kind of approach, now Smile Train focuses on a very, very specific challenge. And having said that, of course, there are a lot of issues around be it malnutrition or general health that kind of determine the outcomes of the work that you do. But what has been kind of your experience in terms of community engagement when it's a specific issue, but wider areas are connected? And specifically when it comes to the COVID-19 kind of a scenario, how did this particular issue or your overall programming in general kind of get impacted from that? And do you feel CSR can play more of a catalytical role along with government, that we don't face similar challenges in future? Like we all saw, like Smile Train works on Cleft. It's dependent upon malnutrition status of the children. Midday meal programs or SNP got affected during COVID. Now, how do we ensure that going forward, if something similar comes up in the near future, we are able to address those challenges? So your perspective of that would be really great.
Thanks a lot, Himanshu, and good afternoon, everyone. And I'd like to specifically, yes, as you said, that we are an organization, we are an international charity which focuses especially on this condition for clefts, and I'm going to tell you that how crucial the role of nutrition or malnutrition is, and how do we kind of work together to solve this. So I have a very short presentation that I'd like to share with everyone's permission. I hope you can share my see my screen.
Yeah, Mamta, we can see that.
Okay, so I just, as everyone said, I think all the panelists, and we are only here, the entire, the NGO sector, and everyone's talking about how the pandemic has helped transform their lives and the kind of work that everyone does. So, cut to our specific area, which is Cleft. So, even here, I think the COVID-19 has impacted all walks of life, and the development sector is no exception. This is very true, especially for child and maternal health, that it gets compounded for a specialized cause like Cleft. The past 18 months have been truly challenging for everyone, but specifically for Smartrin and our work, because most of our partners had to delay surgeries because of the pandemic. It's so difficult for mothers, for parents, for children to live with that condition. And imagine if it has to be delayed and one doesn't know when it's going to be resumed, it's like a death sentence. So some of the, the statistics for this condition are alarming. We know that in our country alone, there are 35,000 children being born every year in just India. And with the pandemic, it is estimated that about 52,000 children were born in the last 18 months with this condition. And more than, generally you look at the medical and the healthcare and the surgery kind of statistics at hospitals, more than 20,000 time-sensitive, life-saving cleft surgeries were delayed just in these 18 months. So you can imagine the kind of, the backlog which is there. And basically leaving children vulnerable to problems, very basic problems like eating, speaking, hearing, even breathing. And therefore, it becomes very, very important for organizations like ours, Smartrin's sustainable model of empowering local medical communities and, working with local doctors to react and act very quickly, so that, the surgeries or the treatments which are on hold are able to, pick up and people start doing the work really quickly, because all these are very, time sensitive procedures. However, in the last 18 months, the biggest challenge has been that of outreach, because we have to go out in the field, teams have to go out and counsel people and tell them that clefts are treatable and so on and so forth. So those, the physical traveling and going out in the communities, that has been a challenge for us as well. Actually, cleft makes newborns, as I said, very, very vulnerable to malnutrition. Without adequate support, it can lead to starvation, even death. Newly born children, as you all know, and we've all talked about it, are missing out on the necessary immunization. And that is, kind of leads to the cleft condition. It worsens the cleft condition. Imagine a child who's not been immunized, and we're talking about either diarrhea, we are talking about, malaria or other, diseases which happen in children, and also compounded by the fact that the child is born with a cleft. So there is a greater risk of death and greater risk of other related diseases as well. And these factors actually put children at risk of malnutrition, especially in the vulnerable groups, like the way we work. Therefore, there is an urgent need to make up lost gains and focus on nutrition especially, and this is critical to tackle child wasting, stunting, anemia. And remember that our kind of work, without that nutritional status and without a child having that right weight for age, right anemic values, and the right kind of physical status, we cannot provide that treatment that we do. So, one thing or the other, one thing after the other actually leads on to the delay, and therefore delayed development for a child. So as I said, that malnutrition actually decreases the quality of life, specifically for the cleft child, speech and hearing disabilities, facial disfigurement, loss of self-esteem. I think we all talk about the physical status, we all talk about treatments, we all talk about, but the most important, especially in the cleft condition, is the psychosocial makeup of a child. It how the person sees himself or herself. So the delayed the treatment, the delayed problems with all of this. Sorry. Yeah. So as I said, that 1 in 700 are born with a cleft. 35,000 children are born every year in our country, and I would really like to stress the importance of ensuring good nutrition for expectant mothers, breastfeeding, investing in nutrition and advancing nutrition on the first 1,000 days of a child's life. And how does an NGO like ours actually make sure that all of this is provided? Of course, we work with local partners. I think here working with the local government and the ASHA workers, whether it's the NHMs or other field workers, is important. We do provide that training. Of course, we provide a lot of funding for them for nutrition as well as for cleft treatment, but to ensure that we all collaboratively working together. Sure, everyone's working. We notice that there are a lot of things which are available, but usually people work in silos. So I think it's important that we are an organization which actually does comprehensive cleft care, and nutrition is the most important leg of the comprehensive cleft care. So we do look to the government, we look at other NGOs as well to collaborate with them to work together. And as I said, that leave no one behind by 2030 is only possible when the society works together to, comes together to address these challenges. Corporate, civil society, government, I think everyone needs to come together to work. Nutrition needs to be integrated at each phase of life course with other sectors such as, health, whether it's education, hygiene, and environment. Auxiliary nurses, midwives, Anganwadi workers, yes, they're really under tremendous stress. We all know that, frontline workers. But I think at Smile Train, we have the wherewithal, we have the know-how, we have the fiscal strength and the expertise to train these people, to empower them, to incentivize them to come and so that whenever they do their regular whatever they're doing, they can have cleft as one of the important agendas which they can address. That if there is a cleft child that they come across, then we have the training, so we can train them, and we usually tell them that how to send them to our hospitals. And the cleft, entire comprehensive cleft treatment to the child is totally free, which is supported by Smile Train. I think there has not been much focus on community empowerment, I think, which is critical for everyone to come together. And I personally think that there has to be a public movement for nutrition security. It's just not one or two people, NGOs or the corporates or the government, which can just tackle this problem and deal with it and solve it. So that's important. In the end, I would just like to tell you about this one initiative, which is India's first national cleft helpline, which is 1-800-103-8301, which is the brainchild of a very good friend of mine who is on this panel today, who's Mr. Joydeep Sen Gupta. And is very instrumental in the organization that he was working for earlier, which was DSK India. So this program was started. It's still doing very good. It's a fantastic program, and I think this is the need of the hour. Communication and awareness, I think, is the need of the hour. People should know about how to deal with nutrition, malnutrition, or cleft treatment, and I think this is an initiative which we can't be, more than we are very thankful to the donors and everyone to support Smile Train with this. So thank you very much.
Thanks, Mamta, for your work bringing smile to the children. And I think smile is the biggest thing one can bring to a child's life and the impact it can have on their well-being. Now, moving forward, point to you, Mr. Kiran, one thing, like you lead a foundation of a Maharatna, like, and has one of the largest budgets in the country for when it comes to CSR. Now, listening to your co-panelists, different kind of perspectives came in terms of convergence requirement as well as outreach requirements and all. What's your view? Where do you feel are what do you feel are the missing ingredients in it? And as Mamta was kind of moving towards that part, it was the end of the presentation. Do you feel there is enough local leadership or community ownership of the initiatives that corporates or foundations get into? To take them forward or to build that public pressure on the government to take those initiatives at scale. Some perspective from you on that would be great.
Yes, good afternoon, Himanshu and others. It's been very interesting to listen to the co-panelists and what they have been doing, and well appreciated work that's been happening. See, if you really look at the programs, whether it is the government programs or the CSR programs or the NGO programs, the intent is always right. Right? Everybody would want to do something good, something which will help somebody. So there's no question about the intent part of it. But for every one of us, whatever program we are doing is going to be the passionate program. So we would own and we would say this is the intervention that is required in community. So again, because we own it, we always feel that, irrespective of whoever it is, whether it is the government, CSR or the partners. But one thing we need to understand is that holistically, what is that we need to look at to see what parameters which have to be raised, which are those parameters which has to be raised. The very important thing is, if you look at, each of us are working in most of the time in silos. Being a foundation where we are mostly into funding, like we don't get into the implementation part of the program. We are into the funding part. So how what happens is whoever comes with a good project proposal in a particular healthcare area, we are willing to support that kind of a thing. So though there is a focus and attempt to be done, we also have difficulties in terms of how do we get a focused approach. This is one, because there is no dialogue between public health services and the corporate majority of the time. Even in aspirational districts, if you look at the way it is functioning, though there is a coordinated effort that is happening, it primarily falls on the district collector or the health officials there on what is the program that should be taken. So one, yes, unless the community is involved, you will not be able to deliver the programs as per the need of the community. We will be doing some, I would say, peripheral impact. I'm not saying that there is no impact. Definitely there is impact. But how can this be strengthened? Is there has to be a collaborated approach between all the players. And that is a key. Otherwise, we are doing, we are building, ONGC is building a big multi-speciality hospital in Shivsagar and Assam. Now that, why did we start doing it? Like, why not we support the government system there? But if you look at that particular place, it's a district headquarters, doesn't even have a dialysis center. A basic dialysis center is not there in the entire district. People will have to go to either Dibrugarh or Jorhat. And that is a kind of a thing. So even for the smallest thing, they would do that. So we said, why not we build a hospital? We will fund it, but it will be run on a sustainable model. See, what we are doing, we are charging 400 rupees for a bed. This is inclusive of the doctor's visit cost. So, which is at a very, very throwaway price. But yes, there has to be the sustainable models, because if you look at, can CSR keep funding health all the time? It is not going to, it's not a solution at all. So unless there is a participation from the community, you will not be able to take these programs to a logical end. So I would say that yes, we need local leadership to be developed. We need to champion on few of those things which are agreed upon by all of us, that these are the major issues that we need to be addressed. And primarily, the collaboration is not only with government and corporates, but it is also between corporates. See, for example, if we are looking at particular block, particular district, couple of us working together is going to make a real change rather than each of us working in various places. So I think when we talk about collaboration, talk about building a platform, talk about leadership, we need to work on all the three, all the players there and see how there can be handoff. Even in corporates, what happens is the focus is not going to be remain same. Based on the decisions at the board level, the focus will shift and also the area location will shift. Can there be a handover? I have been running this program for 3 years. Can I look at my own fellow corporates to see that if somebody is interested so that I hand over the program so that it continues? I feel this kind of a partnership is also the need of the hour.
Definitely. Thanks, Kiran, for your perspective on that. And like you partly kind of answered the next thing that I was going to ask you in terms of, given you come from a tech background, what would be the key strategies? You answered part of it, so I will just ask you one, that do you feel that corporates implement programs in a value for money manner, and how that can be replicated in the government system, and what would be the strategies you would suggest to do that? And any last thoughts on that?
See, I feel the basics has to be addressed. If you look at why there is proper diagnostics doesn't happen in the right time, right place, and why medication has not been able to be given. One is the distance, and we know that the equity of health programs is one major issue. But one other thing from a technological point of view, and where I think CSR should also focus is, how do we support this health card which has been promoted? Because that is going to be the key. Today, if you look at whether it is an urban well-off individual or a rural tribal person, the data is missing. And it also is a practice in us, no, that we don't go to one particular doctor, we keep going to different doctors all the time. And again, there is no shift of data. So this particular thing, whether it is anemic mother to a malnutrition child, if the card, if the health card is there and it is properly tracked, you get a lot of information on what are the patterns within the family, within the region, and within a particular state. So interventions can be planned well in advance based on that. Today, if you look at most of the programs are, though proactive programs are there, the emphasis is given always on the urgent reactive programs. And we always look at ASHA workers will do everything. We will train them, we will build capacity in every aspect of life. But believe me, the Didis are doing excellent work. But then you look at their own internal capabilities. And how many programs can they take to the ground? So it's very important that technology also has to be used related with, how do we equip this health card? Because that is something, how do we fasten this whole process? For me, I feel we need to, instead of supporting in terms of building infrastructure on government hospitals and things, if we work on creating this kind of a system, which is anyway, the government is focused on it, will lead a more proactive approach. That's what I feel. And last thing I would like to add is, see, we need to keep the public health system as the hub. And how many spokes can we create around it? It should be the approach what corporates should take, instead of creating our own hubs. Because unless the public health system takes over and we support them to deliver the health schemes, whatever it is, this dichotomy of that all the time we will be supporting various programs will never end. Holistically, we will not be able to give a solution, but we will be cosmetically feeling very happy that we have definitely done our piece of it. Thank you.
Definitely. Thanks, Kiran, for taking the difficult part of it, the strategy going forward. And I think throughout the panel discussion, we came across a lot of suggestions which one needs to seriously think about going forward and disseminate and educate with the government and at different platforms on how collaboration could happen better between corporates and government and the other stakeholders. I think we're overshooting time, but maybe just we could take one or two questions if the time allows. One very interesting question came was around the prioritization between primary and tertiary care or secondary care in terms when it comes to investment. So any of the panelists who would want to take that, well, most of us or the corporates work at the primary healthcare level. Any thoughts on your planned investments or how you see when it comes to investing at the secondary, tertiary level as well as primary level. Anyone would want to take that? Joydeep, would you like to take that, given that?
Yeah. So Himanshu, it's for us, as I said, that it depends on the need of the community. So we work at all the levels, primary, tertiary, as well as secondary level. And I think most corporate does. It depends upon where we are working. Definitely in the geographical locations where we are working, we need to work at all levels, but the scale will vary. The bigger the scale, our investment would be much more focused on what we want to give. Maybe on infrastructure, maybe somewhere supporting staff, but we need to prioritize on that basis. But we work at all the levels.
Thanks a lot for that. I think so that's the main point, that where the need is, one has to invest in that area. And of late, we have seen definitely that the investments in the primary healthcare from the government side have also increased substantially, which of course should lead to lowering of pressure at secondary and tertiary level, and those levels better able to address the patients who have that need of that kind of care. One maybe, Kiran, last question to you. It was asked much earlier. TB, we didn't discuss about tuberculosis, where India has one of the biggest global burdens. One of the participants wanted to understand if ONGC is doing anything specific in that area. Any thoughts on that?
Yeah. See, we are not doing anything specific to ONGC, from ONGC on TB related thing. We have not taken up any such program as of now. But also, like I said, why CSR is not contributing to TB is a question also that was raised from the same audience. Like I said, it's all dependent on who is passionate about what. And each of them will feel what their area of expertise and they are passionate about that. We have funded huge money on cancer research and thing, because that's an area we thought which requires a lot of investment. Not only in the treatment part of it, but also to look at how do we do early detection.
Right.
That's the key. So there we are funding more on the cancer
side.
Yeah.
No, just to add there, in fact, you are right.
Sorry, if you look at the last 2 years, everything has been on COVID.
Right,
it's
true.
Even
it has taken most of the attention.
So Himanshu, just to, can I add to the tuberculosis?
Sure.
Is that, not only HIV, TB, it's a co-infection, right? So in both the areas, corporates do not fund or not funding it to the level that they are funding at let's say a maternal and child health program. Several reasons. One is a lot of stigma, both for HIV and TB. It's not visible. And then the understanding needs to also evolve around the communicable diseases. Also, the investment is very less on the NCTs as well. So again, it needs to improve. The demand has to come from, again, if we have a platform where corporates can be brought in, because corporates works on an industry forum. So if I go and I was GSK, my focus was always on nutrition. How do you move, how the NGOs move to an industry forum and then bring the agenda towards that? Industry will react accordingly.
No, definitely. There is definitely on TB specifically, there is such a platform that exists led by the Central TB Division. It's called the Corporate TB Alliance, which was supported by USAID and the Union and all. So anybody or any of the corporates interested to work on the TB space should definitely be part of the Corporate TB Alliance at the national level. Over 100 plus corporates are already part of that. Well, thanks a lot. Thanks to everyone on the panel to share your views and suggestions and give your time. Plus, thanks to the participants. I said when we started, there were 150 plus. During the discussion, there were 200 plus people who joined in. Thanks a lot for them to join, and I hope we were able to answer some of the questions or bring some clarity on this space, and hopefully that would help us all work in this area strongly as we move forward. Thanks a lot for your time.